Hello everyone, welcome. Today I will discuss about drugs for bronchial asthma. So, let's first discuss about bronchial asthma. As you already know that bronchial asthma is a allergic reaction to some allergens, and this reaction is characterized by bronchial hyperreactivity. And if the bronchus or bronchial tree is hyperreactive, initially there will be bronchospasm, but later on there will be also increased mucus secretion, and ultimately there will be cellular infiltration and edema. So actually the responses to allergens can be classified in two types: early response and late response. So the early asthmatic response actually a very short response which lasts for about 30 to 60 minutes, and this is actually triggered by exposure to allergen, which actually causes the cross-linking of the IgEs on the mast cell surface, and this cross-linking actually results in release of histamine and leukotrienes, and those histamines and leukotrienes, all of them can cause bronchospasm. So acute asthmatic response is actually characterized by bronchospasm. But in case of late asthmatic response, along with bronchospasm, there is also infiltration of some chronic inflammatory cells like eosinophil and lymphocytes. Especially eosinophils are very important, which releases the mediators like leukotrienes, and those leukotrienes can cause inflammation and also mucus plugging. Very important to remember each of those points. And here, as I have already mentioned, that in case of asthma there is bronchoconstriction or bronchospasm. This is the main reaction, especially in the acute asthma or especially in the early response, and also it's a part of chronic asthma response, and therefore you have to actually do bronchodilation to relieve the symptom of asthma. So bronchodilation is our goal. So here we have our bronchial tone, which can either go to bronchodilation or can go into bronchoconstriction depending on the factors that are affecting them. So we actually want bronchodilation, and we can achieve that by increasing the cyclic AMP concentration in the smooth muscles of the bronchial tree. So we can do that by increasing the activity of the adrenalyl cyclase and beta 2 agonists, especially beta 2 receptor agonist. Beta 2 agonist actually can stimulate the adrenalyl cyclase and can actually increase the cyclic AMP concentration. And if you can decrease the breakdown of cyclic AMP, there will be also buildup of cyclic AMP inside cell, and there is an enzyme called phosphodiesterase which can help you do that, which actually degrades the cyclic AMP to just simple AMP, and there is a drug which can actually inhibit the phosphodiesterase enzyme, which is called Theophylline. So those two drugs, beta 2 agonist and Theophylline, can positively stimulate the bronchodilation. And another way is that you can get bronchodilation, you can prevent bronchoconstriction. So to prevent bronchoconstriction, you have to prevent the mediators that cause bronchoconstriction, and one of them is acetylcholine, which actually binds to the muscarinic 3 receptors, M3 type of receptors in the bronchial tree, and you want to block that receptor. And the way you can block that, you can block them by muscarinic antagonist like ipratropium or triotropium bromide. And there is also another substance which can also cause bronchoconstriction, which is adenosine. You can block the activity of adenosine by theophylline. So you see, theophylline has two mechanisms. One is it blocks or it inhibits the phosphodiesterase enzyme, thereby increases the cyclic AMP concentration, and also theophylline blocks the activity of adenosine. So theophylline improves bronchoconstriction or stimulates bronchoconstriction and inhibits Theophylline improves bronchodilation or stimulates bronchodilation and inhibits bronchoconstriction. Okay, so this is the basic theme you have to carry throughout this lecture, and this is the take-home message from this lecture. Very important to know. And here I have shown you some form of drug release, which is called inhaler. Inhaler is very important for asthma patients, and there are a lot of inhalers, and most commonly the inhalers may contain beta 2 agonists or steroids or a combination of both. So those are the most common type of inhalers that you are going to see in your clinical life. And here you can see the parts of inhaler. Here is a canister which part actually contains the drug, and here is the mouthpiece which helps the release of the drug. So the patient actually holds the canister and the mouthpiece together and presses over the canister, and the mouthpiece is actually kept in the mouth, and then the patient presses the canister, the aerosols are actually released into the mouth of the patient, and then patient takes a deep breath. Okay, so this is the mechanism by which a patient takes inhaler. So beta 2 agonists are the most important agents for asthma, very important, and most of them are inhaled, but also you can have oral forms, but inhaled forms are far better because you need a low dose to have a greater action. And beta 2 agonists can be short acting or can be long acting. Short acting are salbutamol, albuterol, or terbutaline, and the main use of them are acute exacerbation, most important, and also you can use them for prophylaxis for exercise induced asthma. And long actings are actually salmeterol and formoterol, and they are mainly used for prophylaxis, very important. And by prophylactic action, it can decrease the nighttime attacks in case of severe chronic asthma patients, and it also permits dose reduction for other agents. And it has some adverse effects. All of those are mediated by beta receptor, which are tremor, cardiac arrhythmia. As you know that heart has beta 1 receptors, beta 2 receptors are called beta 2 agonist, but also it has some actually beta 1 agonist kick effect. So it is not only a beta 2 agonist, it has some beta 1 agonist effect. So it's the side effect part. And also it can cause anxiety through CNS excitation. Okay, remember all of them, very important to know. So another group of drug are muscarinic antagonist. So you have to block the muscarinic 3 receptor to prevent bronchoconstriction, so thereby by actually allowing bronchodilation. And the most common drugs which are muscarinic antagonists are ipratropium and tiotropium. Tiotropium is actually a long-acting drug, and the most common uses are COPD and asthma. So in case of COPD, the more important problem is secretion. So there is more secretion, and ipratropium has more effect on secretion than its effect in bronchodilation. So it's actually prevents secretion better than it causes bronchodilation. So it's the best drug for COPD. But also you can use it in asthma, especially if the asthma or if the bronchospasm are caused by beta blockers like propranolol. So there is another group of drug which are anti-leukotrienes, and there are two types. They are receptor blockers, leukotriene receptor blockers, and also enzyme inhibitor, 5-lipoxygenase pathway inhibitor. So leukotriene receptor blockers actually block the activity of the leukotrienes like leukotriene C4, D4, E4, and those chemical agents actually causes bronchoconstriction. So anti-leukotrienes block those receptors. So receptor for C4, D4, E4, and most common drugs used are montelukast and zafirlukast. Those are especially good for aspirin-induced asthma. And Xylotone is a drug which actually decreases the production of leukotrienes by blocking the 5-lipoxygenase, which actually converts arachidonic acid to leukotrienes. So 5-lipoxygenase actually prevents the conversion, and it can be used as an adjunctive to steroid. And also you have to remember that this drug is hepatotoxic, so remember that, important to know. And another group of drugs is anti-IgG and IgE antibody, which is called Omalizumab. It is actually a monoclonal antibody which binds serum IgE, and it can be used in some cases which are resistant to both inhaled steroids and long-acting beta agonists. Okay, so resistant cases only. And another important drug is Theophylline. I have already mentioned that Theophylline inhibits phosphodiesterase and thereby increases cyclic AMP, and also it blocks the action of adenosine, which is a bronchoconstrictor. So it has two mechanisms of action. But the more important thing to remember is its narrow therapeutic index. It's a very dangerous drug, so you have to give it very carefully. And the most important toxicity are cardiotoxicity and neurotoxicity. So it can cause arrhythmias, because you know that in case of cardiac muscles, cyclic AMP is an important mediator. So as theophylline increases cyclic AMP by inhibiting phosphodiesterase, it's likely that it can cause arrhythmias, and also it can cause CNS excitation. And one another thing is theophylline is metabolized by cytochrome P450 system. So if there is an inhibitor of cytochrome P450 system like cimetidine or erythromycin, those will actually increase the serum level of theophylline, so they will actually exacerbate the toxicity. Okay, so toxicity increased by erythromycin and cimetidine. And there is another drug in this group which is called aminophylline, which can be used IV, and it can be used in bronchospasm or status asthmaticus. Theophylline is commonly found in a tablet form, and also you can have another drug, new drug, which is doxyphylline. So corticosteroids, which are actually the best effective agent in asthma, actually it is not used in asthma, acute asthma normally, but if there is acute severe asthma, you have to use corticosteroid in IV formulation. So IV steroids like hydrocortisone will be used for acute attack, and the other steroids which are inhaled form, inhaled corticosteroids are actually used for chronic asthma. They are actually the first line therapy, and the most common inhaled agents are fluticasone, budesonide, beclomethasone, but there are some other agents also. They all can be found as inhalational form, maybe in a single inhalational form, or maybe in combination with long-acting bronchodilators or long-acting beta agonists like salmeterol or formoterol. So this is a very common combination that you will see in your clinical life. So the main mechanism by which corticosteroid helps the asthma patient is it actually inhibits the synthesis of virtually all cytokines, and this is very important in case of chronic asthma, because you see that in case of chronic asthma there is infiltration of lymphocytes and eosinophils, which will actually causes production of a lot of leukotrienes and other chemical substances, which causes mucus plugging, bronchoconstriction, and other symptoms associated with asthma. So as it inhibits the synthesis of virtually all cytokines, especially by inhibiting phospholipase A2, they actually can relieve the symptoms of chronic asthma, especially the symptoms of nighttime attack. And for acute attack, you can use hydrocortisone, and the mechanism by which it acts is it actually acts as a permissive hormone. So epinephrine is an important agent that we can use in acute asthma, and we can also use hydrocortisone, because hydrocortisone actually increases the sensitivity of the bronchial tissue to beta-2 agonists like adrenaline, because adrenaline has not only beta-2 agonistic effect, it has alpha-1 agonistic effect, it has beta-1 agonistic effect, it has beta-2 agonistic effect. So your body does have it, and if you give a patient hydrocortisone, your body will be more responsive, or the patient's bronchial airways will be more responsive to adrenaline or epinephrine, as you may say. So this is called a permissive effect. So in case of acute asthma, we use steroids to get the permissive effect, to get a bronchodilation, which is not directly mediated by hydrocortisone, but which is actually by sensitizing adrenaline for stimulating the bronchus to dilate. Okay, so very important to remember for your viva. And if you use corticosteroids in inhaled route, you have bypassed the systemic side effect of the corticosteroids. And most important systemic side effects that you can remember is it can cause Cushing syndrome, it can cause hypertension, diabetes-like manifestation, ulcer, especially gastric ulcer, and osteoporosis. So you don't have this kind of problems if you use it inhaled form, because in inhaled form you use it at a very low dose, and this dose actually doesn't go in a lot amount to the blood. So it actually reduces the systemic side effects. Very important to know. And if you use low dose corticosteroid, it can actually sensitize the beta-2 agonist to its receptor. Okay, because if you use beta-2 agonist for a long time and with a high doses, sometimes the beta-2 receptors get desensitized, and by the way the hydrocortisone acts in acute attack, it can also in other formations like fluticasone or budesonide, they can also sensitize the beta-2 receptors to beta-2 agonists like salmeterol or formoterol. So this is very important to know. So it prevents desensitization, or you can say it sensitizes itself beta receptors. Okay, and the most common side effects of inhaled corticosteroids are oral thrush, because as you know, corticosteroid is an immunosuppressive agent. So if you use it locally, there will be local immunosuppression, and as you take it as inhaled form, it goes through your mouth and through your respiratory tract after passing through pharynx. So there will be candidiasis, because there will be separation of your local immunity, so candida will grow up. And that's why you have to tell the patient to gargle after each puff. So the patient have to gargle to actually spit out the remnant of the corticosteroids that are actually harboring in your oral cavity or pharynx. So you have to gargle. And also the patient can use spacer to actually increase or improve the delivery of the corticosteroids to your lungs, and it can also cause dryness of mouth. And one last group of anti-asthmatic drugs are Chromolyn or Nedochromil. They are not actually used that much, and the main mechanism by which they actually can help an asthmatic patient is the prevent degranulation of mast cell, and they can actually reduce the symptom of commonly found asthma, which is allergen-induced bronchial hyperreactivity. Okay, that's all from me today. Thanks for watching my video, and stay tuned for more